Hi, everyone. It's Peggy Hassenauer. The beauty of a virtual event is that I can moderate and host this event from wherever I need to be, including my car when I need to pick up a kid on a Friday. How about that? I'm just thrilled and honored to have you here for our third and final session today. I love the applause we're getting and the hearts coming up. We've had such an amazing day. We've had two great sessions, and we're going to kick off our third session. And I'm just thrilled to have my co-chair and partner in crime in so many ways, Dr. Christine Chaccio, join us. And I'm going to read her bio because it's really impressive. Dr. Chaccio is incredible. She currently is serving as the section chief of pediatric and adult allergy and immunology, as well as pulmonology. She has dual appointments in both pediatrics and medicine, which is incredible. And we're just thrilled that she's here today. She's going to be talking to us about food allergy and other allergies as well. Her areas include not only allergy and immunology, pediatric pulmonology, and sleep medicine, but she also is really focused on adults with food and environmental allergies, including allergic rhinitis, urticaria, and angioedema, allergies, rash, and asthma. I say very openly and very proudly that I am thrilled to serve with her as co-chair, that this program came out of a concept that we were just chatting about 4 years ago, and she is an amazing clinical partner as she helps me care for my daughter who has very severe food allergies and is thriving and living her best life and heading into high school next week. So take it away, Dr. Chaccio. Glad to have you here.
Thank you so much, Peggy. And again, it's been such an incredible journey from when we first sat and discussed what we can do to help to support our schools for our children with these chronic diseases that we're all dealing with. So it's just been a pleasure working on this with you over the years. I'm also just going to take a minute to plug. It's becoming close to the end of the day, so please give us your ideas in the chat box of what you would like to see for next year, and mark the first Friday of August as the School Nurse Day. We will be here again for you. I have already feedback on more about trauma and more about ophthalmology. I'll reach out right away to our ophthalmology department and see if we can bring an ophthalmologist in to talk about some common conditions, including just vision loss in our kids. So anything else, let us know. I'm now going to switch my hat to food allergy, which is near and dear to my heart, and really why I conceived of this program in the first place is just to help support these really increasing numbers of children in schools who are dealing with food allergies, and all of the adults within the school system who are absolutely doing their best to try and provide a safe and healthy environment for the special needs. So please, whatever questions you have, don't hesitate to put them in the Q&A. We'll address them in our group, or by all means, feel free to email me now or anytime during the year if you have a question that I can help out with. I'm happy to. I know at times my email inbox, as I'm sure everyone, it just gets so full. So if you don't hear from me, do not hesitate to pop something back up to the top of the email box. Okay, I do have some disclosures today. I do serve as an advisor for several pharmaceutical companies as they're developing drugs. I do feel this is an important role for our allergists to make sure that as these drugs roll out, they're done in a safe way that can be supported by all of us providers who are on the ground. And then I serve on the advisory board for two companies who are working on microbiome modulating therapies, which is what I work on in my research. But I will be very clear in my presentation when I'm talking about something that is up and coming and experimental, and when I'm talking about something that is ready for the real world now and FDA approved. So adverse food reactions can be a difficult topic because, of course, what many of us, all of us who are providing care, think of as food allergy is most likely something that's immune mediated, either an IgE mediated allergy that could cause an anaphylactic reaction very quickly after an exposure, or something like celiac disease that can cause certainly delayed and significant reactions. But our children and their parents often refer to food allergy as something that I would consider an adverse food reaction, but something that is not immunologically based, like lactose intolerance. Someone may believe that they have a milk allergy. And of course, we want to be very respectful to our families and acknowledge that they may not be able to eat and tolerate something, but to also come to an understanding about what the risk to that child may be. Of course, an IgE-mediated food allergy, which is where I do my work and where I'm going to focus my talk today, is increasing in prevalence. We now think that there are at least 2 kids in every classroom, and believe it or not, even a slightly higher prevalence in adults with either food allergy that they developed as a kid, or this new pandemic, or this new epidemic of adult onset food allergy. We think that there are still 200,000 emergency room visits each year and 150 deaths thought to be related to food allergy. It typically happens when a food is thought to be safe, and it often still is happening with peanuts and tree nuts, and it does not mean that peanuts and tree nuts cause worse allergic reactions or are by any means worse. It's just that the peanuts and tree nuts are ubiquitous around us, and they just happen to be food allergies that stick around into adolescence, where teens are really taking risks that they probably shouldn't be taking. Milk and egg can absolutely be equally dangerous for those teenagers who hold on to milk allergy, although that phenomenon is more rare. They can absolutely have severe reactions. In fact, the most severe reaction I have ever treated was in an adolescent with a milk allergy. But by and large, what the way we know that a food allergy is an IgE-mediated food allergy is it's something that has a rapid onset and is rapidly reversed. It is mostly something that will happen within 15 to 30 minutes. Occasionally on the long side, it could be hours. This is of particular interest for you nurses who are practicing in the southeast of the United States. You may be aware that there is a new problem with an acquired food allergy to mammalian meat, beef and pork specifically, and it sometimes includes milk as a result of a tick bite. But that is our huge exception, where the reaction won't start in 15 to 30 minutes, but may start 2, 3, 4 hours later. But the symptoms are very similar and the same no matter what's causing it. Skin symptoms, hives, vomiting, diarrhea, coughing, wheezing, tachycardia, low blood pressure, of course, is what we want to avoid, and we don't see often, but we have to all be prepared to deal with. Of course, what I've emphasized here, acute rhinitis and acute conjunctivitis, food allergy does not cause chronic symptoms, as I'm sneezing and wheezing, my eyes are swelling every day for many days. That's more typical of an IgE-mediated reaction to a pollen or mold or other environmental trigger. So these are the most common food allergens today. Milk, egg, soy are more common in very young kids, but are more likely to be grown out of as kids reach school age. Peanuts, tree nuts, and seeds, including sesame. Fish and shellfish are more likely to stick around as kids get older and enter school and high school. The one I really want to bring to your attention is sesame, because previously sesame was not required to be on precautionary labels on foods, but as of January 1st of this coming year, they will be. So I think you've probably already noticed that packaged foods are rolling this out and including it. It's going to help make our kids safer. But keep in mind, it's not all seeds, it's just sesame seeds. So kids who have trouble with other seeds like flax seeds, it still will not necessarily be encompassed in those precautionary labels that's required on packaged foods. Excuse me. So I put this in to demonstrate that although each food allergen is separate, there is some cross-reactivity, but some are surprising. One that is not particularly surprising is shellfish. If you're allergic to shrimp, you are probably allergic to crab and lobster. This is very, very common. In fact, it's uncommon to be able to tolerate one of these shellfish without the other. But what I really want to point out is that a peanut is not a nut, even though we call it a nut. I always joke with my kids that a donut is not a nut, even it has the word nut in it. A peanut is actually a legume, and there is some cross-reactivities, and I would perceive that this is an increasing phenomena, that kids who are allergic to peanuts cannot have specifically green peas, lentils, other beans, but the most common that I see are green peas and chickpeas. They will have a reaction. Tree nuts is very interesting because many of my colleagues will continue to dump tree nuts into one category, but we know now that that's not necessarily correct and not necessarily the best thing for any individual child. So what we do know is that cashews and pistachios, in this, you can see this phylogenetic tree here, cashews and pistachios are very similar to each other, and it's exactly what we see in clinic. If a child's allergic to cashew, they're almost certainly allergic to pistachio as well. Same with walnuts and pecans. If you're allergic to walnuts, you're almost certainly allergic to pecans. Phylogenetically, these are very similar to each other. But as you can see, almonds are really quite distinct, as are coconuts and some other nuts like macadamia nuts, pine nuts that are more rare, but may serve as an important portable protein for kids, particularly as they become more involved in sports. I spend a lot of my time bringing kids into the clinic and challenging to almond once they've started, say, on the swim team, and they're just not able to keep up with the calories they need for the amount they're exerting themselves in the day. And if they're allergic to peanuts and a lot of different tree nuts, an answer that we are also often successful with is almond, and then providing recipes where they can package almond in different ways that would provide them with a healthy and good tasting portable protein. So something that you're probably about to see, if you haven't seen it already, certainly at the beginning of the year, is oral allergy syndrome, also called pollen food syndrome. And this is an IgE-mediated allergy, but it's a bit different. So when you have an allergic reaction to something, you're having an allergic reaction to the protein in that food. And that kind of makes sense because all the most common food allergens are these high protein foods that we eat a lot of. But you can start to have these minor allergic reactions, and it's particularly to fresh fruits and vegetables. So examples would be apples, pears, peaches, tomatoes is very common. But what this is a cross-reactivity to the pollen to the protein that is in pollen. What our immune systems make this mistake of thinking is that you just took a great big handful of pollen and shoved it in your mouth when you're eating a fresh apple, particularly when you're in pollen season. And what happens is kids or adults, probably many people on this call, will start to feel kind of this itching sensation in their mouth that's uncomfortable. And what I have kids mimic in clinic all the time is this claw. They just want to claw the top of their mouth. But it, by and large, is fairly rare for it to progress on to a severe or systemic allergic reaction. And the way we confirm that this is indeed a pollen food syndrome and not an anaphylactic or a traditional anaphylactic IgE-mediated allergy is that this particular protein breaks down extremely easily. So if a child has it to tomatoes, but they have no problem tolerating tomato sauce, that's a great sign it's pollen food syndrome. Another example would be bananas, but they have no problem with banana bread. Sometimes even melons, which are really a common offender because the high prevalence of ragweed allergy, that's the fall allergen that is probably starting to hit everyone like it is in Chicago. If you were to just blend this in a high-powered blender with water and sugar and kind of make an agua fresca with it, that may be enough to take that sensation away. And it is absolutely safe for kids to consume these foods in those tolerated forms if it's been broken down. If they have that sensation with itching, they should stop because it would be possible for them to eat enough that it could start to turn into a reaction, a more serious systemic reaction. But this is very, very, very common when we try to not, or we try to remove some of the fear associated with this because, of course, if you look at the list, these are all foods that we want kids to be eating. if a child is starting to experience that sensation with many of these fruits and vegetables that I have listed here, that's a sign that we'll often start allergy shots, and just good old-fashioned allergy shots that have been around since the 60s, because a good percentage of the time we can get that to pull back and then make it possible for kids to enjoy fresh fruits and vegetables again. I do want to point out that some of these are these traditional food allergens like peanuts, hazelnuts, cashews, the ones that I've already mentioned that cause those traditional severe anaphylactic reactions. So what this does is it makes our false positive rate on our diagnostic tests very high. So this can be tricky, and we know darn well that there are a lot of kids who are walking around with a diagnosis of one of these, but really what they have is just a pollen food or oil allergy syndrome. We are working at some advanced diagnostic tests right now to see if we can start working through this. But if there is ever a suspicion, if you have a child who has a peanut allergy and they ate a peanut, and of course you're watching them very closely, but they don't develop any symptoms, that is something to report back to the parent right away, to go back and see if maybe there's another level of testing that they can get to see if this is can be differentiated between a traditional anaphylactic reaction. So of course, everybody who has a food allergy brings epinephrine autoinjectors into the school for safety. I think everyone is able to keep undesignated epinephrine autoinjectors in the school as well at this time. I'm always happy to write prescriptions. If you need a physician to write a prescription for an epinephrine autoinjector, just send me an email and I'll try and get to it as quickly as I can and just send a prescription your way so you have access to those. But there are more and more devices coming out every year. Of course, there is the pens that many people are familiar with, and now I think most people have seen an Auvi-Q. This is the autoinjector that actually speaks to you, but increasingly prevalent are the generic versions coming into the schools. I imagine you're seeing these more because insurance companies are forcing the switch. And new last year are injectors that are not auto injectors. These are actually traditional injections. I don't love for kids to get these. I try and steer families away, even if it's the preferred on their insurance plan. But because of this, these are going under the brand name Synjepi. I would take some time and go to YouTube and watch and see how each of these different injectors are operated. I think some of these old Adrenaclics or generics, and certainly this one that's not an auto injector, are just a touch more complicated. It's certainly not rocket science, but it's good, I think, to be familiar with it before you're faced with the moment where you have to use it. And of course, we recommend that all kids come to school with an action plan. This is an example of one. I like it a lot. It's available on the American Academy of Pediatrics website for download and can be used by any school district. But this is very clear, I think, about what should be done, and gives you just a little bit more information about the past history. If this child has asthma, we know we need to be watching a little bit more closely at the breathing. If they've already had anaphylaxis in their lifetime, of course, that puts us on a bit more higher alert, and we like to know that. And then it helps you understand if the child has already been trained at home or by their physician to carry their own medication, if it's safe for that to be, and could actually give themselves an injector if needed. This, oh, you know, I think I brought up I may have to switch right here. I have the wrong one, but my partner who is going to present today, I'm very unfortunately sick and was unable to come, but I did want to highlight her work because this has really been transformational in the past few years. We know that part of the part of the problem of treating families with who have a child with food allergy is just the anxiety that spirals around, and it's because we eat every day, so it perceives a risk in every single meal 3 times a day that this child could have a life-threatening event. And it's really hard for families who have had children at home to let go and entrust the school with their food allergic child. And we are seeing an increasing number of counselors who are willing to support our families, both the child and their parents. And Tamara Hubbard, who is going to present with me today, started this incredible website, www.foodallergycounselor.com. And this is a terrific resource because she has started a directory of counselors who feel they have particular expertise around food allergy. And I think would be a very handy resource for you, I would imagine. I know I've treated several kids who, may have been absolutely okay with their food allergy until they've made a best friend at school who also has a food allergy. And some of that anxiety can bleed from one family to another. And I know at times that can be a little bit difficult to manage. So I think these are all great places for referrals. She's got many other resources on here that you can use. Again, my email address, Peggy, how am I on time? I had a couple extra slides, but I brought up my own wrong presentation.
So we're at time right now. However,
okay.
you can certainly join us though as part of the chat and share those. That would be awesome. We're going to have a final panel discussion at the end of the day. We'd love for you to be a part of.
Thank you.
Of course. We're getting tons and tons of applause, virtual applause. I love it, with a few heart balloons. Amazing. I'm going to turn my camera off now just for a sec, and I'm going to introduce our next speaker. Super excited to have another very important topic in the health of our children, and that's diabetes, both type 1 and type 2. We should be talking about various forms of diabetes. And so today we're just super excited to have Dr. Rochelle Naylor with us. Dr. Naylor is an assistant professor in the section of adult and pediatric endocrinology, diabetes, and metabolism at the University of Chicago. Dr. Naylor is a pediatric endocrinologist, and she does a lot of clinical work with patients in the inpatient and outpatient setting, but she also has research expertise in diabetes, including understanding and learning more about genetic and atypical forms of diabetes. She's the co-investigator of the National Monogenic Diabetes Registry here at the University of Chicago, an investigator in the Rare and Atypical Diabetes Network, or RADIANT study, which is a contributor, if you will, to the American Diabetes Association. Her work addresses really so many things that we need to think about in terms of barriers to accurate diagnosis of diabetes, specifically in the genetic space. So she's going to talk about various genetic forms of diabetes, perhaps, and give us a little more information. But Dr. Naylor understanding the disparities in having an accurate clinical diagnosis of the exact form of diabetes really informs best practice in terms of the way we can care for children. Dr. Naylor is also the Associate Program Director and the Director of Diversity, Equity, and Inclusion in the University of Chicago Pediatrics Residency Program. She certainly values mentoring and advising pre-medical and medical students, residents, and fellows to advance medical education and research and to provide equitable, comprehensive medical care. Dr. Naylor, we're so happy to have you with us today, and it's always a pleasure working with you. And it's so cool to have you on so you can share your insights with our participants today. So take it away, Dr. Naylor.
Well, thank you so much for that kind introduction. I am actually, today, I'm not going to wear so much my hat on diabetes classification, and I will mostly wear the equity lens in thinking about the ability for a child with diabetes to get a great education, just like their peers without diabetes. So I'm actually going to focus really on the practicality of taking care of a child who has diabetes at school. I do, hold on a second. There we go. Now it's responding. I don't have any disclosures related to this presentation. And I'm really going to focus, like I said, this very practical on the elements of a school diabetes medical management plan, the diabetes care that is delivered at school, including touching on diabetes supplies and technology. And I did see in sort of suggested topics a deep dive into technology. Today will be a service touch. We'll discuss ketone management, treating low blood sugars, and the likes. And certainly at the time of the panel, I'm happy to kind of go on to a bit more of a forest level, but this really is the trees, the nitty gritty for people who have not already taken care of a child with diabetes in the school setting. So the thing that I do always hammer home, because I spend so much time thinking about atypical and uncommon form of diabetes, is that the term diabetes mellitus itself is an umbrella term, and it characterizes a lot of heterogeneous disorders that share the common feature of sustained high blood glucose levels. But it is really important to understand why someone has high blood glucose levels, because that's going to impact their treatment. So accurate classification is really important. But for today's purposes, I'm really going to be focusing on mostly on children with type 1 diabetes or who have type 2 secondary or even monogenic forms, but nevertheless need to be treated with insulin or have blood sugar monitoring. So when we think about the care of diabetes in the school setting, we are thinking about the care that we can expect. This is going to be the care around meals, the care around snacks, and also the care around activity. So that's resuscitation, that's any school-related sports. But we're also thinking of the unexpected, but yet expected care, right? The time that this child has signs of a low blood sugar, signs of a high blood sugar, or has signs of ketosis. So one of the key things to highlight is the importance of the diabetes medical management plan. It is imperative that every child who has diabetes that needs any sort of management at school, so again, that's all type 1, often monogenic forms, and even often type 2, that they have an updated diabetes medical management plan each academic year. And it's important to remember that they are often seeing their diabetes, clinical diabetes provider quite often, and so there may be updates in as much as 1 to 3 times in the academic year. And so you'll want to make sure you always have an up-to-date plan reflecting their most current care. It is really imperative that, of course, the school nurse, and that's a no-brainer, but also other school staff who are responsible for caring for a child with diabetes are familiar with the DMMP. This is always a no-brainer with the nursing staff in the school, but sometimes people who are responsible when a nurse is not available are not actually familiar. And so really championing that cause is important. And it's important, of course, to remember that this is a collaborative plan between the students, the parents, the school nurse, and the other school personnel, all working together to make sure that everybody understands the plans and also that all supplies needed are on hand. So I'm just going to go through a couple of the important elements of the diabetes medical management plan before diving a little bit more deeply into the care that happens at school. So obviously, the date of the plan is important. You need to know it's current for the academic year. The last clinic visit date is also important. One of the things that you will notice is that there may be children who have not seen the provider in a while, and you're like, this plan doesn't seem to work. Take that as a sign that you need to connect with their clinical provider and say, hey, they haven't been in care and it seems like their doses are not actually working for them. And of course, the emergency contact information for that child's clinical diabetes team is going to be very imperative. You also want to know the level of the child across all of the aspects of their diabetes care. There are children who are independent in giving their insulin, but they actually cannot, count a carb to save their life. So you want to know when it comes to the calculating carbohydrates, blood glucose monitoring, interpreting their levels, insulin calculations, insulin administration, all of that. The diabetes care plan should specify for each of those care tasks whether or not the child is independent, needs supervision, or needs everything to be done for them. And then, of course, they'll have a meal and snack schedule and a physical activity and sports plan. You're also going to be looking for their particular signs and symptoms of out-of-range blood sugars, what their treatment plan is, what type of device you'll be using for monitoring blood sugars, whether it's a glucometer or continuous glucose monitoring systems, CGMS. You'll want to know their insulin dosage and how they are counting carbohydrates, or do they have fixed doses? How are they correcting high blood sugars? And obviously a treatment plan for their ketones and a treatment plan for severe hypoglycemia, particularly what type of rescue medication are they using? I know that I am preaching to the converted, but I think it's always important to just remind ourselves that we really need to partner with students for their diabetes care. And I think that starts with realizing that many children will not want to do their diabetes care at school, right? And it is often because first off, all children want to fit in. And as they get closer to their adolescent years and in the thick of their adolescent years, they desperately want to fit in, and having to do something different around every single meal. This is similar to food allergies, right? Every meal, sometimes sports activity, a classroom party, all of these things, having to do something different, having to break away and visit the nurse can feel, very ostracizing. And so sometimes they are really unhappy to have to share their personal medical diagnoses. And then they also worry about being parented and doctored by others. I have a lot of my patients who will talk about their friends knowing they have diabetes, and then we'll start trying to police what they have on their lunch tray. So we have to start with that understanding, and we also have to make sure that we're making the interactions around their diabetes care as neutral as possible. I always remind my patients, and oftentimes their parents, there's no such thing as a bad blood sugar. There's a blood sugar that's at goal and not at goal. And the important thing is that we know what we need to do for either of those values. We definitely want to avoid lecturing food choices. Obviously, food is highly impactful in diabetes, but really at the end of the day, all of us should be following a healthy diet. And so if you wouldn't lecture a child without diabetes for their food choices, then I would actually say that we should abstain from lecturing the child with diabetes, and we can leave that for full dedicated sessions with the registered dietitian or the educator during the clinic visits. Again, we just want that space to feel safe. Believe their symptoms. Some children don't present, as dramatically with low blood sugars or high blood sugars, or if their stomach is hurting because they have some ketones. They can run into situations with teachers who maybe are not as accommodating, and just be the advocate for them. You are healthcare professionals, and you can always educate teachers and other people who may be less familiar with the various ways diabetes can affect a child's ability to be in the classroom and learning, to make sure that they are having equal access to a good education. As we switch gears into the kind of nitty-gritty aspects of diabetes care, we'll remind you of the remarkable job that our pancreas does for most of us without us having to think about it. Every time we eat, as soon as food touches our tongue, our blood sugar, elevates, and immediately our pancreas is able to sense that rise, that elevation, and immediately release insulin. And what we're trying to do in diabetes is mimic this really perfect job. And we always fall short. The technology gets better and the insulin brands get better. But, right now, we are not able to recreate the physiology of the body, but we can do reasonably well. What we can expect for diabetes care is that we're always going to have to mimic this pattern of having some background insulin going on at all times. And then every time we eat, of trying our best to match the amount of insulin to the carbohydrate intake. We also have to try to match this insulin with the level of activity, the level of stress, whether we're well or ill. And so these are the reasons that we can have high and low blood sugars really outside of even the things that are being eaten. So as a reminder, the symptoms of hyperglycemia and hypoglycemia have some overlap. The ones that we typically think of, is a child feeling tired because their body cannot use their food for energy if their insulin levels are not sufficiently matched to their carbohydrates. Whenever the blood sugar is high, spills in the urine, takes water with it, so it leads to increased urination as well as increased thirst as a result of the increased urination. Very often, children are quite irritable, and sometimes they can have blurry vision, but it's almost something that it's a rarely reported symptom. Hypoglycemia can also have this blurry vision and feeling tired, but then there's some other signs. The irritability overlaps as well, but it's often paleness, which is differentially detectable depending on the skin tone, but the dizziness, the sweatiness, the shakiness, obviously those are all of the significant warning signs of hypoglycemia. It is important to remember that some people have hypoglycemic unawareness and really can be quite low and just not feel a thing. And so ideally, those are the children that will be on CGMs, but that's not always the case. So when we think of monitoring blood sugars, you're going to have one of two setups. You are going to have a child who's using a glucometer, so they will need a lancet to print their finger, they will need test strips, and they will need some level of a glucometer. Or you will have children who are using a continuous glucose monitoring system. There are several of these. There's one that specifically goes with the Medtronic pump that's pictured here. There is the Dexcom that can either go to a receiver that looks a lot like a phone, but it's not, or it can go to their phone, which makes it important for them to be able to access their phone. The Dexcom can nicely be shared, and so sometimes students will share directly with the school nurse and other people supervising their care, which is very helpful. And then this is an example of a flash CGM. This is the Libre, where people will put it on, usually it's like on their arm, and they kind of wave this thing that again looks like the phone, but it's not, it's their reader. They wave it over and they can get a blood sugar. What I want you to pay attention to is this little arrow that's kind of indicating up, and this arrow that's indicating straight. And we're going to talk about that in a second to say, what's the difference between the glucometer and the CGM? Is one better than the other? The answer is yes, the CGM is better, but there are some drawbacks to it. The glucometer measures the glucose level in the blood. It reflects what that blood sugar is in that exact moment. And so that's great, because as long as the glucometer is reasonably made, it tells you what is happening in that moment. It does not tell you, though, what happened in the moment before, and it doesn't predict what's going to happen in the moment after. And that's why CGMs are better, because while they are measuring the glucose level in the interstitial fluid, which means they're a little bit behind what's actually happening, they will show you a trend. So you can see that the blood sugar says that it's 85, but actually it was 100 just a few minutes ago, and it's rapidly dropping, and I should intervene before there's a low, or it can tell you the blood sugar is 85 and it's steady and the child can remain in class. A lot of times there is prediction lows and alarms that help alert of a low before it becomes a very severe low. And also a number of the CGMs will pair with insulin pumps and kind of have a hybrid artificial pancreas system. So for insulin administration, the key elements is what kind of dosing someone is on. They may be on fixed doses where they're sort of supposed to eat between a range of carbohydrates, a min and a max, and they're just always taking a standard dose, say 5 units. And they're and preferably and more frequently, they're on insulin to carb ratio. So they count up all the carbs and you're dividing by whatever their insulin carb ratio is. The same is true for hyperglycemia. Sometimes people will have a scale, blood sugar here to here, take this many units. But more often, and again, more preferably, they'll actually have a formula that's based on their insulin sensitivity, which is how much a unit of rapid-acting insulin would drop their blood sugar. It's based on a target, where do we want their blood sugar to be? And it's also based on a threshold, saying how high does their blood sugar need to be before we would correct them. And this is usually either written out with these different numbers, and then you do the math yourself, or sometimes the formula may be spelled out on the diabetes medical management plan. But these are the two things you have to know about their insulin regimen. Is it all fixed doses, or are there calculations? And again, are they independent in those calculations? In terms of insulin delivery, some children will use syringes. This is pretty unusual. Most children are using pens, and some are even using smart pens. This is the InPen, where it will keep a record of what they're doing, and they can use this app on their phone. It'll help do calculations, and it's very useful for diabetes care providers because we can actually use these reports and look at the care that they've been doing over the time between clinic visits. And then a good portion of children, particularly those with type 1 diabetes, although several with type 2 as well, will be using an insulin pump. The basic components of this are some type of reservoir to hold insulin, a battery, which is important that there are batteries around in case the battery goes low, otherwise the pump will not work. And then there's a way to deliver the insulin. The operating buttons will either be on the pump themselves or on a separate device to control the insulin delivery. And these are just examples of the pumps that we typically use. This is the Medtronic that has its own CGM, and then this is the Omnipod, which is a tubeless pump, and this is the Tandem, which has a tubing. Here, the Omnipod, you use this device to put in all information about blood sugars, calculate doses, and see when you and deliver doses. And here, for the Tandem and for the Medtronic, you put it directly into the screen. Both the Tandem and the Omnipod, different versions of them, can pair with the Dexcom to have that hybrid artificial pancreas system going. And then Medtronic, again, has their own sensor for their hybrid artificial pancreas system. Another important thing to be able to do is to monitor for ketones. Ketones can occur when the blood sugar has been persistently high. They can occur when insulin has been missed. This is particularly pertinent with an insulin pump, because if you've got a bad site, you're getting no insulin at all. And they can occur during illness. And they do represent a medical urgency that can turn into a life-threatening medical emergency if not addressed. So ketosis can eventually develop into diabetic ketoacidosis, which is life-threatening. Usually the DMMP, will specify to contact, when to contact the clinical diabetes care team. Some will say for any ketones at all, others will have some ketone management, and then prompt you only to contact if the ketones are not correcting, if they're worsening, or if the child develops vomiting. The two ways that you will be monitoring ketones, the two possible ways, one is through the urine, and there's instructions right on the bottle and a urine color chart that goes along with the ketone level, and you can also measure ketones in the blood. Finally, we'll touch on hypoglycemia before ending out. So hypoglycemia can occur when too much insulin has been given. This can happen when you've incorrectly counted carbs or incorrectly calculated a high blood sugar correction dose. It can also happen if you stack insulin doses. If you give insulin too close together and the first dose of insulin hasn't finished doing its job, the blood sugar is still elevated because it hasn't done its job, and then you give an additional dose to correct that blood sugar. Failure to eat as planned, or some poor meal absorption or vomiting afterwards, like when developing acute gastroenteritis. These are all of the things that can lead to hypoglycemia. And it can also occur when there is increased insulin sensitivity, and that's with really any physical activity. And for a lot of children, this is the specific time when they are prone to hypoglycemia. And typically for children who are participating in sports and maybe even around gym, they may have some modifications to allow them to safely exercise. Like ketosis, hypoglycemia represents a medical urgency that can rapidly turn into a life-threatening medical emergency. Blood sugars can drop really rapidly, so it is imperative that children who are hypoglycemic are not unaccompanied until the low has been treated. You do want to, if someone has symptoms, you would ideally check with a glucometer check or CGM, but you're never going to delay correcting, and you're always going to make sure that the correction works, right? You're not just going to give them something and then let them walk back to class. No, you're going to make sure that their blood sugar comes up appropriately. When we treat hypoglycemia, we often talk about the rule of 15. So you give 15 grams of rapid acting carbs, sort of pure sugar, right? Juice, soda, candy, sugar, honey, and wait 15 minutes, recheck and recorrect if you need to. And sometimes the DMMP may have modifications for the rule of 15 with slightly lower doses to try to avoid overcorrection. Now, severe hypoglycemia is not defined by a specific number on the meter or the CGM, but it is defined by symptoms. If someone cannot participate in their own care to correct their low blood sugar by taking something orally, that's the definition of severe hypoglycemia. If they need help, I should say, if they cannot do it independently. Unresponsive, unconsciousness, seizures, clearly all of those designate a severe hypoglycemic event. And in these cases, this is when you use your glucagon rescue medications. There are a number of different forms now. There's a standard kit where you have to mix it, but there are pre-mixed syringes, pre-mixed pens, and there's even the Baqsimi, which is a squirt up the nostril, which burns a lot, but is easier to administer than these injection-based ones. And just know that they all come with their own dose range, their own instructions. And so one of the most important things is that people are very familiar with the glucagon rescue medication that each child with diabetes has available. And any child taking insulin or a medication that causes insulin secretion, so sulfonylureas, must have glucagon rescue medication at school. You can typically expect a 20-point increase, and if there's not an appropriate response, you can always repeat the dose in 15 minutes. Often this can cause some nausea or vomiting, so you'll lay the child on their side after administering in case they vomit. And once they're recovered, you need to give more carbs. You gave them juice or candy, or you gave this glucagon medication. This is for treating, non-severe and severe lows. You have to actually give them some complex carbs so their blood sugar doesn't drop again. And then remember, particularly in these severe low blood sugars, they may counter-regulate to try to correct blood sugar on their own. This often leads to a high blood sugar after correction and, often cannot be avoided. So you don't want to worry about that too much. And so to sum up, up-to-date DMMP or diabetes medical management plan is a critical component of providing diabetes care at the school. It is important that parents are well partnered with the school and ensure that their children have all of the diabetes supplies that are needed. I went over the long, extensive list, and they need to be always present at school, including batteries, snacks, ketone strips, all of the above. And then it is important for the school nurse and others supervising school personnel to really partner with the child to, again, assure them an equitable and equal opportunity to be successful in school, including all school-related activities. And with that, I thank you for your attention, and I'll leave my email for at least 30 seconds, but I think you also have the slides that I shared before. And I'm happy to take questions. I'm happy to be emailed. And in the slides that you had, there were a couple other slides that I cut for time, but you can find them and review them on your own. So thank you so much.
Thank you, Dr. Naylor. That was great. Look at all the hearts and clapping. I love it. Thank you again. This was fantastic. We will definitely have you join us for the panel discussion / chat at the end. But I would love to introduce our next speaker, if that's okay with everybody. We're just thrilled and honored to continue this discussion of chronic disease in childhood and how we can help these kids in a school setting. I think the most important thing that we can do today is focus on some of these main topics like food allergy, diabetes, and now juvenile rheumatoid arthritis, but we're super open to continuing this conversation as we move down the line. I turned off my camera specifically because I wanted to make sure everybody can hear me. I'm thrilled to now introduce Carolyn Zick. She is a master's prepared nurse and a family nurse practitioner. She's an advanced practice nurse in pediatric rheumatology at the University of Chicago, Comer Children's Hospital. As I mentioned, Carolyn is a board certified family nurse practitioner and certified pediatric nurse working in pediatric rheumatology. She received her BSN from Madonna University in Livonia, Michigan, and obtained her MSN FMP from the University of St. Francis in Joliet in 2018. At that same time, she was recognized in the Chicago area by the Arthritis Foundation as a medical honoree for her excellence in compassionate care to patients and their families. She has a strong focus on patient caregiver education as well as patient advocacy. She's an active member of the Rheumatology Nursing Society and currently serves on the executive board as the treasurer. Carolyn, we're just thrilled to have you. Take it away.
Thank you so much, you guys. I am so excited to be here. I can't even tell you how excited I am to be here to talk to you guys today about JIA. I'm actually here at our annual Rheumatology Nursing Conference, and I get to talk about JIA again tomorrow. So really, it's just such an honor and pleasure to be here to talk to all of you. And you guys are like so super engaged in your chat and your questions. It is amazing. So I'm going to go ahead and I'm going to share my screen. And I'm not like the best person at this, so let's just see. Oh, good, it worked. So like they said, I am here. I'm going to talk to you guys about juvenile arthritis. This topic is near and dear to my heart, with you guys actually being seeing our patients every single day. So they are there with you guys at school, and we get tons and tons of questions about juvenile arthritis, and really just try to work with our families to just give them the information to help advocate for their kids there at classes. So, okay, there we go. So I have no financial disclosures. So some of our objectives, we're going to define juvenile arthritis, including some diagnostic criteria as well as the subtypes. We're going to briefly discuss JIA treatments. Okay, we're not going to get down into the nitty-gritty of all of the different medications, but really just hone in on some of the super important things that are helpful for you guys in your day-to-day in having these kids in school with you guys. As well as just touch on some really important things that would help us out as their caregivers in just really keeping them on track with their treatments. And then just identify some nursing specific interventions in caring for patients with JIA. So what is JIA? JIA is actually the most common rheumatic disorder in children. It is chronic. It is inflammatory in nature. And so this is a condition that children it's going to stay with them. So these are chronic diseases. There's currently no cure, but the goal of treatment is to get the disease quiet and in remission. And actually its etiology is unknown. So, you know, with so many of our diseases, we don't actually know what is the exact cause. What is our diagnostic criteria? So it's really, really important to know that there is not actually one specific test that you are able to use to determine whether or not a patient has JIA. So unlike our wonderful presentations that we heard on both diabetes or allergy, we don't have a test like they do to be able to say, wow, okay, this test is positive, you have JIA. It's actually all based on their history as well as their physical examination, and as well as exclusion of some other conditions. So the diagnostic criteria based on both the American College of Rheumatology and ULAR, which are some important kind of bodies that help us with our criteria. You have to be less than 16. Why 16? I'm not exactly sure, but it's the diagnostic criteria is 16. Technically, if they're diagnosed at 17, they probably had symptoms since they were about 16. So they'll usually just be put into that classification criteria. You have to have joint swelling for longer than 6 weeks. And why? Because we actually see a lot of kids who will have, so that's where that 6 weeks comes. So there are some other things such as a reactive arthritis that I just mentioned and the Crohn's disease, things like that actually you can see some joint swelling with. So let's just talk real quickly about some other common causes of musculoskeletal pain, because this is kind of where things can get a little bit tricky, and maybe sometimes even families have a little bit of misunderstanding. You can have hypermobility. So these kids, some kids' joints just move more than others. We call them a little bit stretchy. So their joints actually go beyond where they actually should go. And that's fine. That's the way that they were made. But sometimes it can cause joint pain. Osgood-Schlatter is one other condition where you can actually see a lot of joint pain. Kids can have growing pains. That's actually a real thing. I mean, sometimes I think people are like, growing pains isn't real. No, it actually is real. And kids do have growing pains. And also have fibromyalgia or amplified pain syndrome. This is really, really important because also a lot of our patients with JIA in other rheumatic diseases can also have fibromyalgia and amplified pain. So it's really important to understand that we do see this in sports and overuse injuries. So when you think about this as a diagnosis, hey, something might be going on. A limp, they're like, oh, well, it's swollen now, but not again. That's actually really, really kind of telling and might want to prompt somebody to do a little bit more investigation. Joint stiffness. So you see this especially in the morning. Little kids, it's after they nap. But you might see this like in other children. Maybe they're late to school a lot and they just can't get moving. This is really kind of a really important sign. It actually helps us distinguish, is this inflammatory or is it not? You may see function. So during these developmental years, it's super important. You had a kid who's able to do one thing and now they're not. With children with juvenile arthritis. Kids who aren't able to push up on their wrists. This becomes really a big deal when they're doing a lot of their work, right? They're not able to do the push-ups. They really, I mean, aside from just not maybe being able to do them, if they're not as physically fit, but it actually hurts or their wrists are not moving as well, it's very difficult to do that task. Kids refusing to sit on the floor cross-legged. So, you know, circle time. This is a time where you might. So based on the ILAR criteria, types of juvenile arthritis, okay, why is this important? Well, because some respond differently to different medications and things like that, but it's just good to know there are different types of juvenile arthritis. The first one we have is oligoarticular, and that's when a child is diagnosed and they have 4 or fewer joints that are involved. And that's within that first 6-month period of when they're diagnosed. Usually it's about 1 or 2 joints. This is frequently younger children, so kind of like preschool-y age. Usually it's a knee. That's usually the most common. These children sometimes may not be on some of our like biologics. things like that. Their treatment course is a little bit different, but that is one subtype. Our polyarticular JIA is when children have 5 or more joints in that first 6 months. Now, factor positive, or it can be negative. So when I said that in the beginning, we don't really have anything that tells us, hey, this is JIA. We do have some patients, sort of like you might think of adults with a rheumatoid factor positivity. That can be seen in children. It's really, really less common. However, it is more indicative of a more severe type of arthritis. We have children who have psoriatic arthritis, and that can be with or without psoriasis, and that's really important. We have spondyloarthritis or enthesial-related arthritis, so kind of arthritis in the back. Some kids have like low back pain. We see this particularly in like the teenagery age, or enthesitis-related arthritis. They go hand in hand. And the enthesi, just to kind of remind you of that, is the area where the bone and tendons attach. So you get a lot of inflammation in those areas. So we'll see it a lot in the Achilles, a lot of times in their wrists, their elbows, things like that. Systemic onset JIA is really actually a completely different disease. It is juvenile arthritis. Arthritis is involved. These kids are generally really sick, and they have daily spiking fevers. They have rash. They have pretty significant, usually arthritis. They have abnormal labs. This is more of an autoinflammatory condition, but they are a lot sicker looking at them, and generally sometimes are hospitalized, things like that too. Not that our other patients can't be, but generally like not at diagnosis. And then we have, of course, undifferentiated JIA. This is just a little bit of a breakdown kind of on how those subtypes break down. The most common, as I mentioned, was oligoarticular. We have that polyarticular where we have the more than the 5 joints. And like I said, that could be rheumatoid factor negative or positive, but much less common to be rheumatoid factor positive. So as I mentioned before, what causes JIA? Well, we really don't know. What we do know is that there seems to be multiple different components. Is there some environmental influence? Is there a hormonal influence? That could potentially be. We do know that we have a little bit of genetic involvement, specifically with that psoriatic arthritis and with that enthesitis-related arthritis. It's not uncommon to see a kid have an infection that boom triggers arthritis. We have seen it happen after vaccines. Does the vaccine cause it? No. This question comes up all the time, and I'm sure you guys get it. But it's triggering the immune system. And we know with a condition like JIA, it's an inflammatory autoimmune disease. The immune system is triggered. So this is just kind of a breakdown of all of the different things that we think really kind of make that diagnosis and come to that. So as far as treatment, how do we treat it? Really, we are noticing that the early aggressive treatment equals better patient outcomes. That's our goal. We need to get kids to us as the pediatric rheumatology providers to get them diagnosed early and get them treated early. Our goal is a treat to target, and with the goal of disease remission. So what we want to do is target that disease, get the joints quiet, and get that kid in remission, and hopefully keep them there. The diagnosis of JIA, though, unfortunately, is often delayed, and kids are often not referred to a pediatric rheumatology provider. The reason being is frequently their labs are normal. So you'll have a patient who will see their primary care provider. They've got arthritis. They run labs and their labs are completely normal. Well, of course, it can't be something inflammatory if your labs are normal. And that really couldn't be further from the truth. That oligoarticular JIA that I mentioned before, that's the most common. Those kids almost always have normal labs. So that's not a good indicator of their disease. Mostly, these kids are in pain. They actually only experience pain sometimes as the disease progresses. Some children do, but a large majority of them don't. Kids are great and they adapt. So if something causes them pain, they just don't do it. So you'll see them not do certain activities so that they can prevent that, but they don't necessarily express that they're having pain. There's also a lack of available providers. So depending on what state people live in, really depends, or where they live in a state, really depends where they may be able to access pediatric rheumatology care. And that's really a huge issue that's really being addressed within the rheumatology community. But that really is, for a lot of families, there's a large majority of states that actually have no provider at all. This is just a little slide to kind of just show you what a normal joint looks like. And then really what's happening in an arthritic joint. So really the goal of treatment, and I will say sometimes with parents, we kind of have to talk a lot about this, right? Because if their child is having pain, really their goal is to treat their child's pain, which is obviously not inappropriate. But the goal of treatment is also mostly to prevent any joint damage. So what you're seeing in that arthritic joint, all of that inflammation, we want to prevent all of that from happening. We want to treat that. We want to prevent any thinning of that cartilage or any erosions. We know that after a long period of time, if arthritis is not treated, these kids are going to lose joint space. They're going to lose function. They're not going to, and that's what we're thinking about long term. We're thinking not just about today, but long term. What is this child going to be able to do in their 20s, in their 30s, 40s, 50s, 60s? And that's really where we're going with treatment. So this is just a little kind of breakdown of some common treatments of JAA. So we do use non-steroidal anti-inflammatories. A lot of our patients are on them. And this is kind of where you guys might see these medicines too, is the NSAIDs. We do try to prevent our kids from getting as much at school as they can. Usually it's morning and it's evening if they're on a twice a day medicine, but we try to kind of adjust that for them. Major side effects, obviously, as a lot of us know, are GI upset, and there's an increase bleeding. We try to not keep kids on these as the mainstay. For most kids, if their arthritis is significant enough, this is not going to be their only treatment. But you will see that that's something that they use in their treatment plan. Oral steroids. So we really actually don't treat it. That's not the mainstay of treatment, is not oral steroids. Does that mean our patients are not on them? No, that doesn't mean that. But that is not usually their sole medication that is going to control their disease. We might use it in the beginning, particularly for a child that's not functioning or is in a lot of pain, until we can get some of our other medications up and going. But it's not going to be usually the only medication that they get. We also do use some sometimes, especially for that first class of GIA, we will do some joint injections. Generally, oral steroids are not the maintenance medication. Disease modified, and that includes medications like methotrexate. That's actually the most common one that you will see patients, or luflutamide. But generally in the pediatric, and then there's biologics, and we've all seen those on TV. They are things like adalimumab, etanercept, tocilizumab, abatacept. Those are common ones that a lot of our kids are on. Infused medications that they're on are infliximab. You know, the most important thing to know about those medications, both the DMARD as well as the biologic, is the most common overall side effect is immunosuppression. So our patients are immunosuppressed. So that's really, really critical for the school nurse to know. Uveitis. So uveitis is the most common extra-articular manifestation of JIA. What is uveitis? It is that inflammation of the eye, and there's various different types of uveitis. The most common kids who are at risk for uveitis is that most common subtype, which is the oligoarticular JIA kids, as well as our psoriatic kids. Kids who also have a positive anti-nuclear antibody And if they're younger than 7 years of age, they are at higher risk for uveitis. Uveitis is often asymptomatic and nobody even knows that it's happening. Also, kids are also younger, may not be able to express it. This is one of the most important maintenance kind of tests that we do with our patients, is making sure that they have frequent eye exams with something called a slit lamp, which isn't a standard eye exam. But this is really, really critical.
Thank you so much, Carolyn. Should we jump to some questions? That was amazing. And I think since there was a little bit of sound issues at a couple of spots, I bet there'll be a lot of questions for you, Carolyn, but that was absolutely fantastic. Thank you so much.
I agree. I would love to share my screen if I can, or not share my screen, but show my screen. I thought maybe the issue was me. It just looks
right
like
ahead, Peggy. You're
there
fine.
we go. Thank you. So I'm just thrilled to have all of you here. Carolyn, thank you so much. You provided us with just a wealth of information. This last closing panel is really about you, the attendee, asking questions of our nurses and learning more from them and about their practice. But I also want to welcome those who were just on this last session as speakers. So Dr. Naylor, if you're available, great. If not, that's okay. Dr. Chacho, certainly Carolyn, we're thrilled to have you with us. And what we'd like to do is talk a little bit about helping our attendees understand the pros, cons, difficulties, maybe sharing of stories with additional panelists that include our keynote speaker from this morning, Bridget Haroff, as well as Martha Bagato. So Martha Bagato has been working as a school nurse since 2000. She's currently at the University of Chicago Lab School, and we're thrilled that she's able to join us today. Hi, Martha. We'll have you unmute in a sec. Carolyn, great. Carolyn, we'd love to have you join us as well. And then Bridget, of course. But Martha, did her undergraduate and graduate degrees at Loyola, ultimately earning a CNS with a focus on adult hematology and oncology. Her greatest joy, as she shares with us, is watching students thrive and grow up. So we're just happy you're here today. Carolyn, because you kind of ended, I wanted to see if there were any other nuggets or points that you wanted to share with us that you think are valuable as we sort of end the day here.
Yeah, absolutely. Can you guys hear me okay?
Yep.
Okay, great. Sorry, my internet has been super spotty. I apologize for that. I would say, honestly, I think the biggest thing I would love to just have the nurses know is that if they need any information, we are here to support them. Those 504 plans for our kids are super important and are really, really helpful during the day for them. And we just want to make sure that they have everything that they need to help make it successful for them, as well as being able to support our families. So, I'm happy to answer any questions. Anybody can shoot me an email. Happy to provide any education that I absolutely can for them.
That's great. I really appreciate it. This is really about Q&A. So what we'd like to do is spend some time answering your questions for those who were on this wonderful panel. Dr. Naylor, I see a question already about glucose levels. Do you see that one?
I was typing an answer to one. Let me see.
That is okay.
Yeah. Which was let's see. Which one is it?
It's funny. It's funny. It doesn't look like it's on there anymore.
Oh, I was going to say, I've definitely been answering them as we go along. So it might have.
Oh, how about this one? How about this one for you, Dr. Naylor? Even though you may have typed the answer, a nurse is saying, we have a parent who wants us to draw insulin from a vial.
Yeah.
And from a vial of an insulin pen into an insulin syringe and administer it that way. The nurse doesn't believe that may be an effective route, and the parents maybe don't believe that the insulin pen is effective. So what were your thoughts on that?
Yeah, perfect, because I'm a slow typer. So you saved me from having to try to get the rest of that into the box. So I have been saying to a number of questions, I was joking that I'm becoming a broken record, but really reach out to the clinical care team. I feel okay throwing the clinical care team under the bus because I'm a clinical care team, right? But honestly, if there are kind of discrepancies in what the diabetes medical management plan says and what the parents are requesting, then really, it is appropriate for you to have the clinical care team fix that disconnect. And what I was saying in this particular case is, that's not going to be written on the diabetes medical management plan. I couldn't imagine. If it is, then that's a whole nother reason to reach out to the clinical care team. But you can let the family know, like, this actually is not what's written. This is not what I can do. And so we're going to have to resolve this. Now, this family, if they, for some reason, don't trust the pen, then they really ought to go to syringes because, quite honestly, that's kind of like a double dipping of healthcare resources. And maybe, it's not kind of the best way to move forward anyway. So this is something where if they trust the insulin pen or syringe, then they can pair it with an insulin vial. And that makes your job very easy and it can all be clarified in the DMMP. But I do really encourage, if there is a mismatch, go to the clinical care team and say, hey, I need you to fix this mismatch with the family because they're asking me to do something outside of the diabetes medical management plan. And like I said, I'm drawing work to myself, but I really do think that's appropriate. It's appropriate to make sure that the clinical care team is kind of being that interface if the family is asking for something that's really not in the DMMP.
Sure. Carolyn, I'd love to ask you how folks can access you as a nurse practitioner and access pediatric rheumatology. So maybe they have, and this often happens where a nurse will attend a conference like this, and a week from now, some parent brings this up in a discussion group or at the first day of school. How do parents access you as a clinical provider or your team members?
Absolutely. So they can, if they have a child that they feel needs to be referred, certainly they can reach out to our scheduling team at Comer and can schedule an appointment with any of either myself or any of the other providers as well. We are actually in multiple locations throughout the area, as well as Northwest Indiana. And we also have telemedicine visits available. And if they have other questions, if they're like, hey, what about this? Do you think this kid needs to be seen? Usually they probably do. Like, that's always my thing. If you really have a concern that something's going on with this kid, really honestly, just talk to somebody and have them referred. We're happy to see them. But that would be the best way. And like I said, I don't know if my email was on my last slide. I was actually thinking about that today, but if not, I know you can get in contact with somebody. I'm happy to help out in any way.
Sure. And anybody who's on this program right now, who's willing as a panelist or a speaker, can put their email into the chat or into the Q&A. I planned on doing so as well. Because I think that oftentimes I function as sort of the go-to navigator on campus. I've been on campus on and off for 20 something years, and it's been a real privilege to know a lot of folks in both pediatric and adult care. So I'm happy to take questions or take referrals and help you or a parent navigate, or a child care provider. Thank you, Carolyn. I appreciate that. Dr. Naylor, I'll ask you the same question. How do folks see you and your team? As we know, pediatric endocrinologists are scarce, just like pediatric rheumatologists. Where do you see patients? Where do your colleagues see patients? And I know everybody can access you through me, but are you taking new patients, right?
Yes, I am definitely taking new patients. I see patients on the Hyde Park campus in the DCAM clinic, not the Comer Children's Clinic. Very important. I have a lot of people who are like, we were sent to the wrong building. We are in the DCAM building and not the Comer Children's Clinic. And then my colleagues also see children both at the DCAM in Orland Park. And I think that covers our ped sites for now. Hopefully we'll, in the future, have a little bit more sites to offer, but I am definitely taking new patients at the DCAM.
I so appreciate it. Dr. Naylor, you have a boatload of questions, a lot of great questions about diabetes management. Specifically, it looks like maybe some disconnect between the care team, the parents, and the school nurse in terms of like what they actually need to do, and frankly, what they can do in a school setting when a child's blood sugar is completely normal. Should they be running one Skittle down the hall, right?
Yeah.
Like really, like what can we do here about that? And it's not really written in the care plan. So that's interesting. So what are your thoughts on that?
Yeah, and this is where I kind of laughed at that broken record, because I've been answering some, and I'm like, contact the clinic, contact the clinic, contact the clinic. And I really will keep saying that. I think it's completely okay to say, you know, the diabetes medical management plan doesn't tell me to do that. So if there is a part that's missing, you know, I'll reach out to your provider. You should also reach out, but I really do think it is, it's actually great to see these questions. As a matter of fact, 'cause I will tell you, of course, right now it's hot season for doing these medical management plans. And it actually, for everyone moving forward, just know that I will be doing some expectation setting that I haven't often done because it didn't occur to me to need to. Definitely, I have some nurses who will email me directly and we troubleshoot things. But I will say, absolutely, to me, I look at all of these questions and I think that if this is my patient, this would be my job. And so I really do advise reaching out. And I did say for that one Skittle question, no. So the DMPP the DMMP should be saying exactly for what blood sugar we're going to intervene, and the family will have to really discuss with the physician or the provider rather, their concerns and kind of come to a happy ground. But for all of these, I say definitely reach out to the clinical care team to help set those expectations and fix missed expectations.
I appreciate that. Dr. Chacho, do you want to talk a little bit about your team and specifically about where your team sees patients, not only you, but your colleagues?
Absolutely. So we are available here on the Hyde Park campus. We also have clinics in the South Loop, Orland Park, and then Maryville, Indiana. I think this week the University of Chicago broke ground on a whole new facility in northern Indiana, which we're very, very excited about, to expand services into northern Indiana. But we're planning on moving to that site, which is just one exit away from where we are now in Crown Point, Indiana. And then our plan is to move up into to our downtown location that the University of Chicago is already running, hopefully in the next year or so.
It's very exciting. Thank you. So another question for, I guess, Dr. Naylor and Carolyn. How often, it's interesting, it's for all three of you in many respects. What we did sort of by accident was focused on these sort of autoimmune conditions or immune responses to our bodies, right? Between diabetes and rheumatoid arthritis, and of course, food allergy and allergies in general. So what kind of overlap is there, right? So, Rochelle, do you have any patients in your practice that have pediatric RA? And Carolyn, you got patients in your practice with diabetes? Just curious.
Well, we certainly do together. So I can think of at least one person who comes to mind.
Yes, we do.
And then I have reached out to Dr. Chacho multiple times about, the IgE level of my patient with eosinophilic esophagitis. So there's definitely lots of overlap that happens between all of them because they are all autoimmune. And so, or at least type 1 diabetes, again, multiple forms of diabetes, but because of the autoimmunity, when you have one autoimmune disease, it automatically makes you at higher risk for other autoimmune diseases. So we definitely share some patients.
I appreciate that. I do want to point this out too, that as you share patients with multiple health conditions, and as you move forward in your practice as attendees today, we are happy to provide, one-off education, whether it's in person or virtually, for school staff, for school nurses, for health personnel, for parents. I've seen some really fantastic programs happen as part of PTOs around disease management in schools, whether it's diabetes, food allergies, what have you. So we're happy to put that together. We do it all the time. We have an amazing group of diabetes educators that do a lot of great stuff directly with families and teachers. Oftentimes there's a designated person in a school setting if there's no school nurse, which is a bummer. But sometimes this happens where there's a designated school employee who supports the family with diabetes, and we can train that individual as part of our practice. So these are just things that we can offer. And I think it's good for you to know as attendees, we take care of a lot of patients who have a lot of crossover diagnoses.
Peggy, can I just
please jump in?
One quick comment. I want to say, years ago, we would go from school to school and kind of do these education sessions, but now we have the luxury of having Zoom to help us out. So we have increasingly popped into different schools or other providers' offices over the noon hour and just had either formal didactic, we'll give talks, or we're just happy to have conversations and answer questions. So Technology has really helped. We offer telemedicine across the country. If families just want to schedule a visit and just chat for an hour about their disease. So the technology has really, although come about because of COVID, which has caused us all a lot of grief, really changed some things for the better, that some of these education opportunities are more easily done.
That's a great point. We have so many attendees here today who are not from Illinois. So if you have a family member or a family that you work with, for instance, in your school, and you are in Florida or Massachusetts or what have you, certainly there's great programs and services there. But like Dr. Chacho said, if you contact me directly, you can certainly, pick my brain in terms of what your child might need, and I can help navigate so that the family can maybe get a second opinion. We do second opinion virtual visits quite a bit. If we can see the child from another state and insurance covers it, we will. But I think it's really valuable for you to know that we're here for you, regardless of where you live, as Dr. Chacho said. Any other questions in the chat that are burning? Okay, so Dr. Chacho, I've been seeing more students with cold urticaria. Could you speak to that? And do you recommend that they have EpiPens? Awesome question. I actually get that myself when I'm outside too long, like skiing or something.
I thought that was an excellent question because, again, this isn't something that has been proven, but in my practice, I'm seeing more and more cold urticaria, certainly. And no, I do not necessarily prescribe EpiPens for everyone. It is rare for cold urticaria to result in anaphylaxis. It can happen. I tell our families that, the place that we've really seen problems is if a child jumps into a cold pool on a 90-degree day or into a lake in those first hot days of summer. It's that sudden shift in temperature could cause a systemic allergic reaction. But by and large, cold urticaria is just urticaria. It's just those hives that are annoying. That being said, I do have some families who have requested an EpiPen because they feel more comfortable, and I think that's absolutely fine. But no, I don't think it's necessarily necessary for everyone. On the flip side, there is also a heat-induced urticaria. So we see some kids who struggle in the summer months going out into the heat without breaking out into hives, and vice versa. We have some kids who really struggle to go out in the snow in the winter months because of the hives. But we can usually get this under control with either daily Zyrtec dosing, or if we need to, something called Xolair. It's a biologic injection that works very well for this to keep it under control.
Interesting. Okay, I appreciate that. Carolyn, this one's for you. Can you speak to TINU? So I'm assuming you know what that means, but I can spell it out for you. So it's tubular interstitial nephritis and Uveitis syndrome.
Yes, super rare.
Yeah, very interesting question, but it says I had a student with this a number of years ago, and this student was followed by rheumatology, nephrology, and ophthalmology. So, what is this? Even though it's rare, what is it for those of us who don't know?
So it's actually a condition that is uveitis. So they have that eye inflammation. They can also have renal disease. Actually, one of the patients that I'm thinking of most recently was actually presented in renal failure. So it's a combination. So it's like this cluster of kind of condition that is treated with immunosuppressive therapy, which is frequently then where we are become involved. So it's a very rare autoimmune condition. They generally don't have a ton of arthritis along with that. That I have seen. Like I said, I've only seen like 1 or 2 kids with it because it's super rare.
Sure.
But one girl that I'm just thinking of that I just transitioned to adult care, who's doing really great, had the uveitis, but came in full-blown renal failure and then did well, was off dialysis and everything. So realm of rheumatology diseases.
Thank you. And Janet Zimmer is asking you for some information regarding RA care plan examples. So
yeah, everybody just email me. I will get you that. You know what? I'm just afraid that once I responded, then I lost somebody's email. So if you can email me, that would be fantastic. I will get that to you. We have those available. And if any of you are in a state that you don't have a pediatric rheumatology provider, so I'm happy to help you find what you need to educate your families and educate the staff and make things easier for everybody and for our kids. So just let me know and I can put you in touch with resources.
Carolyn, if you can send Peggy and I a copy of an example, we can see if we can get it posted on the website. So everyone can come back to the website and be able to download it throughout this year.
That would be perfect. Yes, I will do that. I will get that to you guys.
Great. Thank you so much.
Absolutely.
Okay, so this is a good one. This is a good one for Rochelle. For Dr. Naylor, how should we handle a situation when we follow a diabetes management plan, and when to call 911 for a student who has high ketones, is hyperglycemic and lethargic, but the parent refuses transport to the ER? We had this occur and the EMTs left the student because the parent refused transport over the phone. Tough one. That might be a Bridget question too.
I'll do my first stab where I did answer that in the chat as well. And that's why, again, I'm a broken record, but I think all areas where the DMMP is not clear should be brought up to the clinical team so they can address it more clearly. Specifically in that situation, what I suggest is that they either write in there that the nurse or other supervising school staff can make that determination, or they can specify that the school team should call the clinical care team and the on-call provider can make that determination. Again, it's all something that the parents would have to sign. So the clinical care team has to go over with the parents and say, here is the thing. But it is, I think that one in particular, it is completely unfair, actually, right, to leave an ill child in the school setting and kind of tie hands, to kind of give the care that is deemed necessary. So I think that one in particular really could be addressed in either of those two forms. And maybe the latter is the kind of the easier one, where it's the clinical care team who ends up saying, no, I said to do this. And then, that way they will, see the family back in clinic and can discuss those things. But I do think that is definitively one where the care team has to write a DMMP in a way that can't happen again, because that's obviously the kid could get very sick, and that's not fair to have then the school, responsible for that and yet not being able to access care appropriately.
Sure. Well, I want to thank our speakers for this third session. Amazing, amazing day with you, Dr. Naylor, and you, Dr. Chacho. Dr. Chacho, you can stay with us as our co-chair, of course. Dr. Naylor, I want you to know you can sign off at this point. We're super grateful for your time. Thank you for answering so many wonderful questions. Lots of great applause. And we're ending with the final segment of our day with, as I mentioned, Martha Bagato, who's with us from the University of Chicago Lab Schools. Amazing. And she's also here with our keynote speaker today, Bridget. And we're going to talk a little bit about various aspects of clinical care. So, and what it really looks like in a school setting. So Carolyn, you're welcome to sign off as well. I can't thank you enough for your time. Everybody can work through me to engage this audience and vice versa. And we'll see you again. Thanks, Carolyn. Thanks, Dr. Naylor.
Thank you so much, you guys.
Thank you so much. I've dropped my email in the chat. Feel free, if I didn't get to your question, please just send it to me. Thank you so much. This was wonderful. Bye-bye all.
Awesome. Take care. So Martha, you have a lot of experience in healthcare, and you have a ton of experience with, children in school. So I'll start with you, and then I'll of course go to Bridget. If you were able to attend pieces of this today, or even if you were just able to glean something from the discussion we just had, what did you learn today from a clinical standpoint regarding kids in schools that maybe you didn't know before? I caught her. Martha knows everything almost.
No, I really like the historical perspective, and this doesn't have to do with kids, so maybe I'm not answering the question, but that whoever did that historical perspective about school nursing, that was so refreshing. It was a set point to bring me back to earth after, orbiting COVID and everything else for so long. So, that was fabulous. The urticaria, that rarely transitions to anaphylaxis. I didn't know that because rarely have I seen cold urticaria, but when you do see it, it is just so bizarre. It's just so amazing. Yeah.
I appreciate that. Bridget, how about you? I mean, you've seen just about everything in your practice, but what did you learn today maybe that you weren't aware of, or something new that struck you?
I have to agree with Martha. I really liked the historical overview of school nursing that Dr. Ali Sontag presented. And it was just really nice to be able to take a much deeper dive into some of these conditions that we don't always see very often in school, like the arthritis. I haven't seen too much of that. So it was really nice to get more information on that. And of course, anything mental health related is always of a benefit to our students. So that was really nice too.
I think that was great. I would agree. I want to encourage those of you who are still with us as participants to ask questions. I really want you to ask questions of Bridget and of Martha about their experience as school nurses. Bridget, tell us a little bit about, if you don't mind, the school environment you're in right now. So the size of the school, the type of school, how many kids are sort of under your care? Do you have a team of, unlicensed professionals working with you? I'm just curious.
Sure. So I am in a slightly more unique role. I am considered an administrator here in my district. So I work a 12-month administrator schedule. I have the privilege of overseeing nearly 20 absolutely amazing nurses.
Wow.
So we have 12 buildings. We are a pre-K through transition district, a unit district. We have about 7,500 to 8,000 students here in the district that we serve. So we have, I have, including me, 10 certified school nurses, which is absolutely incredible. I have some very amazing classified non-certified nurses. And I also have a health clerk at my high school, and I have an administrative assistant. And this is my second year here, and it's been incredible. Just they are a wonderful team, and I am so thrilled to get to work with them every day.
So your team is big. So
Yeah.
That's amazing. How do you build a team that big in your school system? What does that take? What does it take to train them and to educate and support them? And is it rare that you have that many school nurses? It seems like a ton in a fantastic way, but it's not something you often see.
Yeah, statistically, we are an outlier because we have at least one full-time school nurse in every building all day. And at my high school, I have 3 nurses, and in my middle schools, I have one full-time nurse and one part-time nurse in each one. And so I can't take credit for building this team. It was definitely my predecessor, Eva Detloff, that really put in the work and the advocacy. But we're also really lucky because the district administrative team has been supportive of nursing and really found the value in that. So it's easy for us to keep going as we are. But I have worked with other school nurses and been in other districts myself where that's not always the case. And sometimes it is a struggle to help our non-medical colleagues to understand the benefit of school nursing and what school nurses do, and why it's important to have certified nurses, and what the certified nurse can do that, maybe the classified nurses can't. So it's a lot of advocacy, again, using that data, because we know in education, it's data and it's dollars that really drive our decisions, right? So if we can use our data to prove that we are worth the investment, we're going to get much farther.
I appreciate that. Martha, tell us a little bit about your team. So the lab school, if I'm not mistaken, is pre-K through 12, and it's separated into lower, middle, and higher school. How many nurses do you have on your team? Or I could ask also about sort of other allied health personnel.
Yeah, so just a comment, someone in the chat said, boy, I wish my supervisor was a nurse instead of an educator or a teacher. And my response, or my 2 cents, is, how about having a lawyer as your supervisor? That's our situation, but it's not bad. We just got, thanks to COVID, money to hire another nurse. So we have 2,100 students and 5 full-time nurses and 1 part-time nurse. We don't have any auxiliary staff. It's all RN staff.
Cool.
We're pretty, it's an independent school, so we have a lot of resources. I just want to comment on one of the questions or things that came up regarding food allergies and birthday celebrations. Our school, especially, well, it goes all the way through high school. Food is center. Food is as important as taking AP classes in high school and, you know, showing up. Just food is a big part of our program. So birthdays are celebrated with food, and I don't see them anytime soon stopping it. We were able to get the start time for high school moved later, which I know a lot of places would like to do, but struggle with it because of the benefit of additional sleep for adolescents. So we're able to make that leap, but I don't see them getting rid of celebrations, even though kids celebrate their birthday at school with their friends, with their grandparents, with their parents. They have 5 cake opportunities, which is pretty ridiculous. And that's just them. And even the half-day pre-kindergarten school kids who are there for 4 or 4.5 hours a day are eating cake with icing. Anyway, to get around, to address the anaphylaxis issue, not obesity, but the anaphylaxis issue, is the students with severe allergies their parents provide safe snacks, special treats for them, be it an ice cream sandwich or something that can be stored in the freezer. So when the pop-up birthday celebration comes, you know, they can have a special treat, and there's no, you know, reading ingredients at the last minute or, you know, asking someone who made the cake what's in it. So, yeah, it's imperfect, but 22 years, I've learned to take your wins when you can.
I think that's great. You know, my children are at Nurse Martha's school, and I want to give a shout out to Nurse Martha in just a second, but I wanted to add that there's a policy in the younger grades that it's peanut and tree nut free. And in an exhausted moment as I was making lunch for my son when he was in kindergarten, I threw in this pre-prepared Nutella and sticks, something that we had gotten from Costco. And he came home just so mad at me because he had to sit outside by himself and eat lunch. And I tell you, I never made that mistake again. And I really appreciated that the food allergy child was not the one who was separated from the classroom, but my child, because I made the mistake, was separated from the classroom, and he went out in the hall and he ate his hazelnuts by himself. And I learned my lesson. He never let me forget again. But I do want to share a story, and Nurse Martha, you may or may not know that you are a lot of the reason that we have this, because I have a cousin who survived cancer when she was very young, in grade school age, and then lost her father a few years later to cancer. And she credits Nurse Martha for graduating on time, for surviving the whole really rough childhood. And she recently graduated from nursing school because of Nurse Martha, and has started working as a nurse. So huge thank you from my family. I mean, really, you mean so much to our family. I can't thank you enough.
Thank you for sharing that. I didn't realize it went that far.
It did. Many years our families have worked together. We have a few, I think Peggy got disconnected, but we have a few more questions. There's one that I thought that I would address because I think this is so interesting. What has caused the exponential increase in food allergies? And it goes alongside of what has caused an increase in rheumatoid arthritis. And one of the things we study here at the university is how the good bacteria in our gut has shifted with our diets. You know, all this sugar, it kind of all goes hand in hand that we're eating, and the reduced amount of fiber. We really think, in the antibiotics we take, we've shifted the bacteria in our gut to these bacteria that just can't control our immune systems. The good, healthy ones are very good at controlling our immune systems. We can see that really clearly in the projects that we're working on. But when that happens, we think it makes kind of the immune system twitchier, and then it's your genetics that kind of decides whether you'll end up with an inflammatory disease and juvenile arthritis or diabetes or food allergy. So these all seem to go hand in hand, these modern illnesses. And But we think it all comes back down to food in the end, not a ruthless plug. But looks like Peggy is hopping back on.
So it's interesting. I can't hop on with my video in this moment right now, but you can hear me, which is great. Sorry, I lost you for a few minutes, guys. Dr. Chacha, where were we?
So we were just hearing about the schools, and I was giving a shout out to Nurse Martha, who's been in my family's life for many years now. And I just started working on some questions again, but I know you had some questions prepared for the panelists at this point.
No, sure. I think one of the things I'm interested in, Martha, is how you can perhaps share a best practice story regarding how you interacted with a family's care team. I think sometimes that can be maybe a little bit easier for you because you're on the University of Chicago campus and maybe you have some, better interaction with some of the physicians or not. But I am curious if you could share kind of a best practice scenario where maybe a child was newly diagnosed with a particular issue and you were able to really interact with the care team in a powerful way.
Leukemia. We got word in late summer of a nursery student who was diagnosed with acute leukemia. As you all know, leukemia is pretty rare. We hadn't had a student with hematologic malignancy in many years. Contacted the care team. The student had a fellow who was gracious enough to come over, across campus and brought her slide deck and did a presentation, an overview of leukemia to everyone, the teachers, the counselors, principal, other support staff and nurses and everything to really bring the temperature of the room down and make people feel empowered and competent and so that this student could have the best possible experience at school. And you can, get permission from the families and being able to call them up, being able to consult about medication dosing, blood pressure, monitoring blood pressures with students who maybe are starting on medicine for attention. And again, at the University of Chicago, in my previous life, as you had mentioned, I'm an adult was an adult hem-onc nurse. So I was very comfortable with paging anybody for anything and took that skill over and, paged, feel comfortable calling the infectious disease practitioner on call. For, a parent who's concerned about a bite injury. Is it, how contagious is hepatitis with a bite injury? And, I can only do so much quick research, but being able to say, hey, I talked with the pediatric infectious disease and here's the risk of hepatitis and here's what, they recommend after a bite injury to do. Things like that really have been wonderful. The other care team that we all have is poison control. Oh my gosh. Those people have kept me out of high water so many times. I can't even explain. They're just fabulous. So don't ever hesitate to reach out to poison control, whether it's somebody got hot sauce squirted in their eye or the kids ate the berries off the viburnum bushes in front of the building, whatever it is. Oh my goodness. Sorry.
Yes, I have to echo Martha on that. My latest call was someone got glow stick in their eye. They cracked a glow stick on their hat and it went in their eye. So future information, it is not toxic to the eye if only a little bit gets in there.
Good to know. Good to know. I mean, never a dull moment for you guys, I'm sure. Bridget, somebody asked a question, which I think is super valuable. I think us as nurses, we get stopped in the grocery store parking lot, right? By somebody's neighbor's aunt's cousin who has a question about their toenail. So we're used to this, but somebody asked a really important question about where their role begins and ends in terms of the management of the healthcare or acute needs of the adults in the building, faculty, staff. Somebody can't breathe, somebody wants you to look at their finger. How can we really, as school nurses or health providers in any setting,
maybe set up those expectations at the beginning of the school year with senior leadership and with school staff. Bridget, what do you recommend?
I definitely recommend talking with your HR department and your district administration, because a lot of districts have that laid out in terms of expectations. So like for our district, when I have new employees come in and I meet with them and talk about the role of the school nurse, I tell them that if they're injured at work, the nurse can provide some basic first aid, if they're in the building and available. If not, our district utilizes company nurse, which is like an 800 number that they have to call, and they speak with a healthcare professional trained in adult care, who then goes through and triages them on the phone and directs them where to go and get care. But beyond that, I would definitely talk with your HR, because again, with adults and colleagues in the building, you're really kind of getting into that area of sensitive health information, and how much health information do you really want to have about your colleagues, and what is appropriate and what's not. And that a lot of that may have to do with whether or not you are part of a union, because some of that will be stipulated in your union contract. So I would recommend talking with HR, getting a clear outline of what's acceptable, what's not, and then making sure that they're giving that message to the staff as well, so that it's not just coming from you saying, I don't want to do this. It's coming from HR saying, here's what we expect. And if you're having a life-threatening injury or, a life-threatening illness, of course, the school nurse can, jump in and help when they can until EMS arrives. But for your everyday kind of medical issues, you need to go see your PCP.
Yeah. And what is, really is, if you're a school nurse, whether you're new or you've been around for a while, if you don't know what the occupational health or HR policy is for yourself or your colleagues, if you get hurt on the job, who do you call? What do you do? Right. This is just like a finger stick situation. If, we get stuck with a syringe in the hospital, who are they calling? They hopefully shouldn't be calling you, right? Who are they calling? Is there a hotline through the district where they go to sort of a centralized HR health service? What does that look like? Because I think the liability here is something to take a look at. And I think the level of complexity and needs of these individuals isn't necessarily something you want to be involved in. So awesome question. Great question. Any other thoughts, Bridget, regarding, some best practice that you felt like your team has really achieved? So one of the things I've been thinking about is kind of case conferences or collaboration between the schools. So what do you do in terms of connecting with your school nurses, whether you have a team meeting and you review cases? Do you review high-risk student health situations or diseases maybe you haven't seen in a while? How do you really engage your team as an administrator to make sure that you're reviewing cases and talking?
I would say communication is so important, and we have built into our week PD time every Wednesday, and because of Zoom, we've been able to host meetings weekly, and I have nurses on 3 different schedules, so not everyone can always attend. So what I found helpful was I would record my meetings and then put them in our Google Drive so that the nurses could go back and review anything that they may have missed. But it was a really easy way for us to keep in touch and make sure everyone was on the same page, especially with changes with COVID, because we were getting changes so frequently, either from IDPH or from within the district, that was one of the best ways we could connect. And if there were more specific student cases, we would just stop the recording, and it was a way that we could talk through things. Oh, Peggy, I think you're muted.
Sorry about that. Martha, how about you? How do you connect with your team members in various buildings, perhaps, or do you guys meet once a month, whether it's virtual or in person?
At my school, nurses are the only ones who don't go to meetings. Like, we are the default for everything. Oh, so-and-so's in the meeting. Here, take care of this intoxicated kid. Oh, all the counselors are in a meeting. Here, take care of this parent who's having an episode, a mental health challenge. We don't, meetings aren't our jam because we get pulled out of them. I will say this again, keeping up with, conferences or IDPH recommendations or City of Chicago recommendations or state recommendations. Whoever goes to the meeting will, take notes and share it with the team. Google Drive is a perfect example. The beginning of the year, of course, we'll have meetings, and probably quarterly we do, to talk about staffing and so forth.
Thank you. I appreciate that. I think many of you had other questions, a lot of funny, interesting poison control type questions. So maybe that's going to be a topic for the future. Bridget, this one might be for you. It said, Lauren says, we request an emergency medical information form be completed at the beginning of every year in case we need to call an ambulance. Do you think this should be done? I mean, my knee-jerk reaction is yes, but I guess maybe they're asking more specific information on this form, and the nurse is questioning why they're asking it. I don't know.
Yeah, I guess that would come down to the district specifically. We do an emergency card every year that parents fill out with just general information about, does your child have asthma, allergies, seizures, diabetes, kind of like the big categories. And if they say yes, then we would contact them for additional information and make sure that we get all the appropriate emergency healthcare plans from the family. So I guess I would ask what emergency medical information would be on the form that you wouldn't already have.
Okay, well, Lauren just clarified. Thanks, Lauren. She said this is for staff.
Oh, for staff.
For staff.
Yeah, again, I feel like that's not a school nurse role, because you're getting into that HIPAA, protected health information. I would say if the district wants emergency medical forms for staff, then your administrator for the building should be responsible for keeping that if it needs to be in-house. And if not, it should be your HR department. That should probably not be something in your office.
I love that. I appreciate that, because you're right. And depending on the school nurse office and how it's set up, that stuff may not be locked. I mean, also interesting HIPAA issues. Very interesting. And this is an interesting question too, for Bridget or Martha. Maybe a dumb question, but I've been a nurse for a long time in a hospital setting. I've never worked in a school, but school personnel, school nurses are bound by HIPAA. Is that right? Right,
Martha,
Bridget?
do you want to take that or me?
Oh.
So yes, we are always bound by HIPAA, but in the school setting, we are also bound by FERPA, which is the Federal Education Privacy Act. And sometimes FERPA and HIPAA are a little bit at odds, but HIPAA would be for our health specific information and how we communicate with our healthcare providers and our families. And FERPA covers anything that we are keeping like records of. Martha, did I miss anything?
Yeah, no, I think you said it quite well.
Great. I appreciate it. So I think we'll ask maybe a couple more questions and wrap up for the day, but people are putting a lot of cool things in the chat, which I appreciate. I wanted to sort of address this last question. So what's your advice for setting policy when teachers send students to the office? This school nurse says, I feel like I get students sent to me for every little thing. I could see that. And it's interfering with our ability to provide duties and services for other students or other things that are going on. So how do you sort of divide and conquer? It's sort of an interesting question about how you triage, right? You need like a nurse, like triager for the people who are popping down to the office. So Martha, how do you handle that? What do you guys do?
We dig out from under all of those students. And depending on the age, we'll set policy. Middle school, all students, unless there's, missing limb or blood or anaphylaxis, must come with a note from their teacher. So the teacher has to write a note. They can't just send them down. And often that process of writing the note is going to sidetrack the teacher. So they're going to tell them to sit down, wait 30 minutes before you go down because you got a drippy nose or whatever it is. So that, and it's also safety. It accounts for where, knowing where kids are. Also then having a direct conversation with teachers. I don't know if it's because I've turned 60, but I'm able to be much more direct with adults and saying, hey, we are dealing with testing today. We're doing shield testing for COVID today. We're very busy. Please do not send anyone down unless it's really necessary. We have provided you with the first aid kit at the beginning of the year. If you need new supplies for that kit, let me know. If you don't feel comfortable with something, let me know and I will help you, increase your comfort level, or let's work together so you feel comfortable that your kids are getting what they need and our time is being utilized to the best of its ability.
Yeah.
And sometimes we have those conversations quarterly with the same teachers. And then sometimes you bring the principal in with that and make it 3 of you together talking about things.
Sure. Bridget, thoughts on that?
Yeah, definitely everything that Martha said. And as those students get older, and the older middle school and high school, they may benefit from like their own little triage stations. So I've seen in some health offices, the nurses have set up like a self-care area. So an area that has extra contact solution and wax for braces and Band-Aids, those little things that students come in and say, I need some lotion, my hands are dry. Well, is that really an appropriate visit? No, but could they stop by on their way between classes, get some lotion or some Vaseline for their lips and then be on their merry way to class? Sure. So I think that's helpful, especially as they get older, to take some accountability for themselves and being able to learn to help themselves.
I like that. I like a self-care station. I do like that. Would you prefer?
Like for those kids who got anxiety too, sometimes just that morning check-in with the nurse before they start their day. I've had students who, it's a scheduled check-in with Nurse Martha before they go to class. I'll take their temperature, I'll listen to their worries, and they go up to class, and then we're done for the day. I don't see them again. And then they grow up.
Wow. Yeah. I think folks are ready for a school year and nervous about it at the same time. But with your help, I feel like we can get there. As parents, I feel like we can get there. It's so interesting. Maybe it's because I'm a nurse. Maybe it's because I know you guys are doing, God's work. I am like, what else can I do for my school nurses? Like, what else can I do for you? So I am so grateful for you sharing your perspective, Martha, and for being with us today. And Bridget, for your point of view as not only an administrator, but somebody who's been a nurse for a long time as well. So thank you so much. What a tremendous day we had. I think we've answered most of your questions. If we haven't, we're still happy to after this. My email address is peggy.hassenauer@uchihospitals.edu. I will put it in the chat before I leave today. But please reach out if you need us. And we look forward to maybe, an hour-long Facebook Live event, maybe before or after Halloween, to see how everybody's holding up. It's always, the Halloween checkpoint is always like a tough one for parents and kids, as well as school nurses. So maybe we'll do a Facebook Live event and we'll invite folks to come on in and share their funny horror stories, and maybe we'll provide some words of wisdom. Dr. Chacho, any parting words?
No, but again, just a huge thank you for everyone's participation today and engagement. And again, we are learning from all the comments you're posting. Thank you so much for that. We really look forward to seeing you again next year, first Friday of August. And please, again, send your suggestions. I'm taking notes. I've got Post-its all over the place. I'm trying. Peggy and I will meet in the next couple of weeks and start working on the program for next year. Thank you.
Yeah. Thanks again, everybody. Have a great day and have a great weekend.